£1,200,000 has been awarded to medical researchers at Queen's Medical Research Centre, University of Edinburgh, Royal Infirmary Edinburgh, Heriot-Watt University Edinburgh, and the Scottish National Blood Transfusion Service by the Medical Research Council to develop a machine to control the quality of transplanted material in type 1 diabetes transplants. To understand the importance of this award, I investigated the background of this story by looking into diabetes, transplants in diabetes as a therapy, and how this machine works and how it could help. But first, let's find out about diabetes. It's probable that diabetes has affected humanity for as long as humans have been on the planet, although it wasn't recognized as a condition until the 20s. The first reference to a diabetes-like condition can be found on the notes of Egyptian physician Hesi-Ra in 1552 BC, when he noticed in some patients cases of frequent urination and emaciation. It wasn't until 250 BC when Apollonius of Memphis baptized this condition as diabetes, which is the ancient Greek word for siphon or to pass through. And in 1675, Thomas Willis added the Latin word mellitus to the name, meaning honeyed or sweet, because of the sweet taste of the urine of diabetic patients, not a technique that modern doctors currently use. For sugar to appear in the urine of patients, clearly there was something wrong with the metabolism of glucose. It wasn't until the early 20th century, when Canadian scientists Frederick Banting and Charles H. Best were awarded the Nobel Prize in Medicine after figuring out that the hormone insulin had a key role in controlling blood sugar after a meal. It turned out that the insulin is produced by a cluster of cells called the pancreatic islets, which, as the name suggests, resides in the pancreas, an organ located in the abdomen that has a role in digestion, but also has an important role in the production of insulin. With malfunctioning pancreatic islets, it results in poorly controlled blood glucose levels, the condition known as diabetes. Diabetes is a group of metabolic disorders characterized by high blood sugar levels over a prolonged period of time. It can manifest itself in two different types. Type 1 diabetes affects about 10% of diabetic patients, while the remaining 90% have type 2. Both types involve a lack of insulin in the body, but while type 2 is a reversible condition, type 1 needs a daily injection of insulin to control blood sugar levels. I interviewed Professor Forbes, who is the clinical lead in Scotland for type 1 diabetes transplants. Good morning, Professor Forbes. Nice to meet you, and thank you for your time in midst of these difficult times.
Pleasure to meet you.
You've been carrying out transplants on people with type 1 diabetes. How does it work?
So, type 1 diabetes, as you know, is a condition which is characterized by high glucose levels, and people with type 1 diabetes cannot produce insulin, and so they're dependent on insulin injections to maintain healthy glucose levels. But in some people, we do transplantation of these insulin producing cells or islets, and technically what happens is islets are isolated from a donated pancreas, and they're actually injected under radiological guidance through the main vein of the liver into the patient's liver, and they actually sit within the liver and produce insulin. So in other words, it's not actually an open transplant at all. It's very, very minimally invasive. And after that, we see that blood glucose levels are much better controlled.
All right. So that sounds very interesting. And how many of these transplants can be carried out a year?
So typically in our center, we'll do one islet transplant in a month. So typically in any given year, we'll do 12 to 15 procedures.
And exactly how many of these transplants will result in a positive outcome? What's the success rate?
So it's a very good question, because as you know, how do we define success is a key question in any area of medicine. And how we define success in islet transplantation is really stabilizing blood glucose control. It's not so much that we're trying to get people off insulin injections completely. We're trying to stabilize their control, and we're also trying to get them to resense when their blood sugars drop, because this can be very dangerous when people get what's called a hypo or hypoglycemic episode. And so in terms of, if we define it in terms of stability of blood glucose control, the success rate is high. About 95% of people would have a positive outcome. Very few people, probably about 20 to 50%, depending on where you are in the world, will be independent of insulin injections.
Up to 20. Those are some pretty high statistics. Do you believe these outcomes could be improved, or do you think that this is about as good as it gets?
I think the ultimate goal should be insulin independence, so freedom from insulin injections. That should definitely be the ultimate goal. So I think
Absolutely.
There's a huge amount that we do to actually redefine success, if you like. But people, we transplant the most vulnerable people with type 1 diabetes, and at the moment, the people that get it, their blood glucose control is stabilized. What can be improved is the numbers of people, our capacity to transplant. That is something that we should be trying to improve, and that which with collaboration with the Heriot-Watt University, we're hoping to improve.
All right. Thank you. That's really interesting. I don't think that this type of transplant is generally well known in public domain, unfortunately. And it's important, I think, for people to be aware that this is also part of a donor program. So.
Absolutely. And you're absolutely right.
So, Professor Forbes, we've heard about how you and Heriot-Watt have been working together to realize this new device. If your research is successful, what impact would you expect this would have on the islet transplantation program?
If our research is successful, then we can utilize donated pancreases that have been exposed to this ischemic time for longer periods with success, because we would be able to accurately look and see how many of those islets are actually alive, and if it meets the criteria which is recommended by the NHS, British Transplant Society, of being greater than 70% viable islets, then we can actually transplant islets from those donated pancreases. So we could start to use maybe 10% more of the donated pancreases, which means that we would be able to do more pancreas, more transplantations, more islet transplantations in the people that needed it. Because at the moment, people are actually waiting on the waiting list for over a year to get their islet transplant. So it would shorten the waiting times, I think, considerably.
That sounds very interesting. And I guess while we're on the topic of time, have you any idea of how long this will take exactly? And what is the typical time this will take to develop so it can be used in humans?
As a sort of an estimate, I think it will take probably around about 5 years to start to really realize this technology and roll it out into islet laboratories.
Thank you so much, Professor Forbes. Thank you for your valuable time today. and best wishes with the transplantation program and your research.
Thank you very much. Thank you for interviewing me today.
I will now interview Dr. Brown, who's an associate professor at Heriot-Watt University and works in the field of bioelectricity. Good day, Dr. Brown. Nice to meet you, and thank you for taking the time to tell me about your work.
Well, thank you, Frederick. It's a pleasure to talk to you about our work on diabetes.
I would like to ask you about how this new initiative between the University of Edinburgh and Heriot-Watt started. But first, I wonder if you could tell us about the device that you are researching.
Thank you, Frederick. When islets are made ready for transplant, they come as in a small vial of solution, a small test tube full of liquid, in which the islets are suspended in a medium, like a kind of soup. The medium is a special transport medium to keep them alive. And when we get them, we don't really know how many of these islets are alive or dead. We can't tell. We can't tell very easily at all. And probably they die because of the trauma of the isolation. Some of them die, and also because of the physical stress of being transported. However, fortunately, all cells in the human body contain small electrical potentials. They're like little batteries. And some cells, like neurons and islets, when they do their job, and in the case of the islets, that job is to detect glucose, they become electrically what we call excitable. They produce a very distinctive electrical pulse. And that signal can be measured. We can measure that. Only fully functional islets were able to make that signal. Islets that are damaged are unable to generate the potential to make these signals.
I see. So effectively, you give them a glucose challenge and measure the pulse?
Yeah, exactly right. Not knowing the islets are alive is a big problem, and knowing that one is alive is kind of not really useful. So what we're doing is we're simultaneously measuring the electrical potential from thousands of islets at the same time, and that immediately gives us a percentage of the cells which are electrically active in the preparation. So they're kind of only using a sample, but it's a bit like these are representatives of the whole population. We're making a detector effectively and a separation device, a biomedical disposable chip, if you like.
So will this chip fit into a computer?
Yeah, the chip can fit, and effectively is in a computer. It's a cellular machine interface that detects the signals, and not only that, it also counts the number of live and dead islets. And so we'll simply report back after processing and counting to the clinician the percentage in live and dead islets in a sample.
That's very good news for people that suffer from type 1 diabetes. Thank you, Dr. Brown, for your time today, and the very best with your research and development of this new device.
Well, thank you, Frederick, for the interview.
Could this be the dawn of a new era for type 1 diabetic patients? Will future generations look back at diabetes the same way we now look back at tetanus or polio? Are we witnessing here a historic moment in the history of medicine? It might be too early to tell exactly, but what we do know is the hard work that is being put into this research. Thank you for listening.